You have a 26-year-old athlete who presents with tight and painful right forearm after intensive weightlifting. On exam, the forearm is mildly tender and sensation is intact. Passive stretch elicits minimal discomfort. The physician is unsure whether this represents evolving acute compartment syndrome. What's the best next step? A, immediate fasciotomy. B, observe and reassess every 4 hours. C, hourly neurovascular exam and repeat pressure measurements as needed. D, CT scan of the forearm. And E, administer mannitol and assess response. What's the correct answer? So the correct answer will be C. Okay, hourly neurovascular exams and repeat pressure measurements as needed. In low clinical suspicion cases, you should observe carefully, reassess hourly, and repeat pressures if the signs worsen. Remember that fasciotomy is not appropriate without high suspicion or pressure data, because fasciotomy is a big thing. It's a big procedure you're going to do, so make sure that you are sure. Now, the only recognized treatment for compartment syndrome is fasciotomy. That is like definitive treatment. And early fasciotomy can help to save the limb. So when are you going to do fasciotomy? When there's a clinical suspicion of compartment syndrome and when the compartment pressure in the compartment is more than 30 millimeters of diastolic pressure, then you want to do your fasciotomy. So remember, fasciotomy is the definitive treatment. Because remember that tissue damage becomes irreversible 4 to 8 hours after compartment pressure has increased. So if you don't act quickly, we are in trouble. And fasciotomy for established acute compartment syndrome after 6 hours of onset increases the rate of infection and amputation. So if you wait, dilly-dally, and you don't act fast, and eventually you go on to do your fasciotomy after about 6 hours of compartment syndrome, that increases the rate of infection and amputation.